TopMedTalk.
Welcome to TopMedTalk. This piece has been supported by an unrestricted educational grant from bioMérieux. Welcome to Conference Highlights. This piece is about acute kidney injury, especially in the context of perioperative medicine and the surgical patient. At POM 2021, we assembled a distinguished panel around this subject, hosted by Andy Shaw, Chairman of the Department of Anaesthesiology and Pain Medicine at the University of Alberta, and Mike Grocott, Professor of Anaesthesia and Critical Care at the University of Southampton. They began by speaking with John Prowle, Senior Clinical Lecturer, Intensivist Nephrologist at Royal London Hospital in East London. Have a listen.
By background, I trained in intensive care and nephrology. I almost solely do intensive care these days. I do a few weeks a year on the renal unit, but I haven't actually done that during COVID. But academically, I work with Rupert Pearce, and we have a big interest in perioperative medicine and outcomes after critical illness and the long-term consequences of short-term harm. And so as somebody with a nephrology background, I've had a long-standing interest in acute kidney injury, but I'm particularly interested in the long-term outcomes of acute kidney injury and how we assess those and what the consequences are for the patients. And I'm interested in this not just in the context of critical care, but particularly in the context of perioperative medicine. And we've done quite a bit of research in that field as well as in the ICU.
You know, as an intensivist and nephrologist, you do sit nicely at the intersection of perioperative medicine and acute kidney dysfunction. And so a couple of years ago, you and I put together a consensus conference that tried to bring these two communities together in Cambridge. That paper has recently been published. Can you tell us a little bit about that?
Sure. In brief, it's long been an organisation within the ICU and particularly the acute critical care nephrology community, which has held a number of consensus meetings. And indeed, this was the group that really generated the rifle criteria, which latterly became the Cadigo criteria, and really invented the whole concept of acute kidney injury. And that group has been very successful. They have a well-established format of identifying research topics and areas of clinical consensus. Colleagues in the perioperative community have picked up the ball and perhaps run with it even better by establishing the Perioperative Quality Initiative under the leadership of Andy and many other colleagues, and adopted a similar approach to looking at problems in perioperative medicine. Actually, I would say perhaps then being able to refresh some aspects of the approach and really produce some very strong outputs in that space. And because people like Andy had been members of both communities, there'd long been a feeling that we should bring the two groups together to cross-fertilise. And we felt that the area of perioperative acute kidney injury was particularly interesting and an exciting one because it sort of allowed us to achieve numerous goals. One was to bring these two communities together and really enable us to share knowledge about the processes which we make these consensus conferences and establishing areas of common research priority and areas perhaps where there is differences and we could better understand as a community how we might move forward. And also because perioperative acute kidney injury is a great complication to look at in the setting of surgery because it may be what we say a sentinel complication. It's measurable in the majority of patients. It's strongly associated with adverse outcomes. It tends to co-locate with other complications. And we've got a well-established set of risk factors and maybe some things that we can do to help improve both short and long-term outcomes. And so the idea wasn't to be kind of just kidney-centric, but to really have this as an exemplar of a great way in which we could approach the refining practice and refining research in perioperative medicine. So we decided we would meet in Cambridge in the UK in September 2019. We brought together a faculty, and the way in which these meetings work is that the groups are defined beforehand. They do a literature review, including some targeted search strategies. Usually these individuals have quite a deep knowledge of the existing literature in those areas to produce a mini evidence synthesis in the areas, perhaps before the meeting. And then it's really a question of actually defining what the questions are in each domain, going back to the overall group in a plenary session to check that those questions are relevant and well aligned with the other groups, and then developing answers to those questions or identifying areas where there is uncertainty about the actual answer to those questions. And then from that, developing some additional research questions, coming back and sort of serially refining these with the groups. And then there's a period of post-conference activity that is writing and refining to sort of dot the I's and cross the T's. The other major thing is that we try and develop great visuals in order to express the concepts that we're trying to communicate, particularly in something which has a sort of temporal aspect like acute kidney injury, because that tends to be the things that are most reproduced and understood out of the meeting and add most to the educationship of the clinical community.
Where is that paper published, John?
So that paper's been published in Nature Reviews Nephrology, a high-impact reviews journal, part of the Nature stable, and that's available open access. It's freely available to the community. You don't have to have a subscription to Nature Reviews Nephrology, which might not be on every Department of Anaesthesiology's list. That was published a few months back. I think the only final thing that I would say is the kind of unifying feature of the way in which we then approach acute kidney injury as a perioperative complication throughout this kind of preoperative risk assessment, the post-operative sort of detection phase, the treatment phase if it's arisen, and the follow-up and outcomes phase, was to use this concept of a kidney health assessment. And this is kind of a concept that might cross over to other organ systems as well, where one kind of has a focused evaluation based on clinical history, examination, the information you already have from the clinical record about the state of the person's kidney health, their potential risks and prognosis. Then one considers some focused investigations, which might include, for instance, novel biomarkers, might include some imaging. And then one develops a kind of synthesis of what you think the patient's likely trajectory is or risks are, some treatment recommendations, which may involve things like a focused review of medication, considering the risks and benefits for that individual of interventions such as non-steroidal use in the perioperative setting. And this kidney health assessment concept can be applied anywhere throughout the process. So it can be applied to follow-up afterwards, where you're kind of assessing the kidney outcomes, you're determining their risks, you're determining what kind of follow-up they need. Does it need to be a nephrologist, or is it just a check UNE at 3 or 6 months with a primary care provider? As much as it can be applied to the preoperative setting, where one is looking at sort of focused risk assessment for that patient and determining what level of monitoring they might need and whether they need any adjustments to their planned perioperative journey. That's the key theme that comes out in the paper.
One of the things I remember from that meeting is we were very careful to make sure that the concepts and some of the ideas that were developed would be deployable all around the world, regardless of practice setting.
Andy, Mike and the panel then moved their attention to Marlies Ostermann, consultant in critical care nephrology at Guy's and St Thomas's NHS Foundation Trust.
During my training, I felt that acute kidney injury was the area which interested me most. And following training in Germany and the UK, I was very lucky in exploring this more at Guy's and St Thomas's, where I now practice in a large intensive care unit, where we sadly see a lot of acute kidney injury, including acute kidney injury in patients undergoing surgery.
Can you make some comments about the definition of acute kidney injury or acute renal failure or acute kidney disease, why we need all these different terms, what they all mean, and how you think it's likely to evolve over the next 5 years or so?
During my training, I was dealing with acute renal failure, as it was termed at the time. And I remember distinctly being asked by a senior cardiac surgeon in a renowned institution in London whether I could define acute kidney injury. And to my embarrassment, I was unable to do so, because at the time, in 2004, there were more than 30 different definitions and criteria for acute kidney injury, or acute renal failure, as it was called at the time. It occurred to me that people who were looking into this, including researchers, were forced to make up their own criteria. Fortunately, the ACI group at the time tackled this issue and essentially developed and proposed some criteria. These were the Reifel criteria. They also proposed to change the term acute renal failure to acute kidney injury, because clearly failure intuitively implies that our organ function has ceased completely, and that isn't always the case. So 2004 was a major year because we changed from acute renal failure to acute kidney injury, and for the first time we had some potential consensus criteria, i.e. the Reifel criteria. Very quickly, a different group proposed a different classification, which was the AKI classification. The definition was similar, but differed a bit. And so people got confused again. And then, to the credit of Cadigo, a new consensus definition was proposed and published in 2012, which essentially incorporated the concepts of rifle and Akin. At this point, I should say Cadigo is a non-profit organization which focuses on developing and implementing evidence-based medicine and evidence-based practice related to kidney disease. And they took all the comments on board and merged the rifle criteria as proposed in 2004 with the Akin criteria proposed in 2006, and essentially developed and publicized the Cadigo definition and staging classification. This was in 2012. This was a major achievement because for the first time, clinicians and researchers had something to work with. And although it wasn't perfect, but at least it ensured that people and clinicians, anybody really looking after patients with kidney disease, was using the same language, a major step forward. But as clinicians used the criteria and researchers used the criteria, it became clear that there were still some limitations. On top of everything, the field moved forward and new diagnostic tools were developed, and generally the interest in kidney disease evolved, and we suddenly realized there was so much more to learn and there were so many things we didn't fully understand. Since 2012, when people realized that not every episode of acute kidney injury is the same. Acute kidney injury in one person is not the same as acute kidney injury in the other. The Cadigo classification, at the moment as it stands and as we still use it, is based on serum creatinine, an increase in serum creatinine, or a fall in urine output. So two very simple biomarkers. They are available all over the world, they're cheap, and they can be used. But the classification as it stands, so giving fixed values for a rise, either in creatinine or a fall in urine output, implies that every patient with acute kidney injury is the same, and that's clearly not the case. It also has some other limitations because we know and have realized now that these two biomarkers, creatinine and urine output, also have limitations. So both lack sensitivity and specificity. For instance, you can have serious tubular damage or damage to tubular cells with even histological changes in kidneys without an immediate creatinine rise. So this is hidden from clinicians at the bedside. At the same time, you can have a rise in creatinine in patients without any change in kidney function because the creatinine is not completely renal specific. It may go up as a result of interaction with drugs or some laboratory problems, or interferences in the laboratory, for instance. So both the markers which we use have serious shortcomings and limitations. Furthermore, creatinine takes a while to rise. So if we inflict an injury to a kidney, even tying off an artery also, it takes 24 to up to 48 hours before we see a rise in creatinine. So they are late markers. And again, this then limits our ability to do something about it. So with this in mind, so the awareness of the shortcomings of creatinine and urine output, the development of new tools, imaging tools, biomarkers, and so forth, a greater understanding of some molecular changes in different types of acute kidney injury. The Cadigo steering committee agreed that it may be necessary to look at the definition of acute kidney injury again. And following a controversies meeting in 2008, where experts highlighted the fact that the current definition is probably no longer fit for purpose and may over or under diagnose acute kidney injury and limit our ability to deliver care, They have agreed to bring a group together and look at the current definition and criteria again. And this will probably happen in 22-23.
Starting to see the questions jump up on Slido. First one, I think is for you, Marlies. When should we be diagnosing AKI using the Cadigo criteria? Continuously, daily, weekly, from before surgery, and for how long?
Good question. Patients undergoing surgery are clearly at risk of acute kidney injury for numerous reasons related to the type of surgery, the type of anesthetic, and obviously pre-existing kidney health. And the POQI AKI expert group suggested that kidney function should be assessed pre-operatively as part of a general kidney health check. And at present, we use creatinine, but it should be complemented by a urine dipstick. Again, urine dipstick being a very, very simple, cheap marker of kidney health. Now, during surgery, at present, we don't have any tools to monitor or diagnose acute kidney injury. There may be tools available in the future, but at present, we just have the urine output, which clinicians, anaesthetists, and surgeons monitor. And then post-operatively, we have, again, the creatinine value, but as I've already said, the creatinine takes 24, 48, sometimes up to 72 hours to rise after an insult during surgery. So it would be very late. There are new tools available. There are new biomarkers available, which have been tested, in particular after cardiac surgery. And again, there are some new biomarkers. Any biomarker, whether it's creatinine or any other new biomarker, obviously has a kinetic profile. And there are some which rise within 4 hours after the original insult. So amongst the cardiac surgeons and the Cardiac Surgery Association, it's been proposed that patients after major cardiac surgery should undergo new biomarker testing within 4 hours or after 4 hours after surgery to really explore or identify those at highest risk.
We then move to Sandy Kane-Gill, Professor, Pharmacy and Therapeutics, University of Pittsburgh School of Pharmacy.
So I am a pharmacist, and at UPMC, I'm a critical care medication safety pharmacist. So I get the pleasure of working on many quality improvement projects to prevent, to manage medication errors and adverse drug events. I have taken a particular emphasis for drug-associated acute kidney injury, focusing on things such as nephrotoxin stewardship. The idea that we can promote kidney health by thinking about it kind of in three different segments, which is putting in initiatives that would allow for early detection of a patient who has acute kidney injury, thinking about ways in which you can instead identify patients who are at high risk, before the AKI occurs, so you can intervene early and maybe never have acute kidney injury develop. And then for those patients who do develop acute kidney injury, the opportunity for really good follow-up so that there's a possibility after that AKI where it turns into AKD after the 7 days, but before the 90 days when CKD is determined, that you can intervene at that time and potentially prevent progression from AKI to CKD. So from a larger perspective, it's about what kind of initiatives that you're thinking about in those categories so you can be very strategic about what you're intending to do. And I think it can be facilitated a lot with the prevention and also with the detection. A lot has been done, and there's been several publications recently from a systems perspective with regards to using electronic medical record or health record alerts to identify patients. So far, the evaluations have mostly been around for patients who you're looking for early detection. Nick Selby and group in the UK looked at 5 different hospitals in which they put an alert in place to identify an individual who has developed acute kidney injury and to notify the clinician appropriately that has happened so that they can intervene. They even took that intervention to a higher level for patients with stage 2, stage 3 acute kidney injury. These clinicians were called to notify progression for that particular patient so that they could consider appropriate management. And with this approach, they found some improvement in process outcomes, better medication management, just better management of the patient overall, following items within the Cadigo AKI guidelines. They also found shorter days of acute kidney injury and some other outcomes such as that. They did not find a decrease in the number of incidents of AKI. In actuality, it seemed to have gone up, but they just think that was about better detection, and that in itself was a success, right? Finding it more quickly is a particular benefit so that the patient can be better managed.
You introduced, Sandy, the notion of ranking of commitment, which I really liked as an idea. Can you expand on that a little bit?
Sometimes we do things within an institution and we're not necessarily strategic or planned with regards to it, right? So we have this managing a patient one way, and Andy's a different way, and John a different way, and they're all doing it slightly different, and not necessarily in an organized fashion, but they're very committed to their patients. And if we're more strategic about it and have more definitive initiative, then we can, from a health system perspective, be more cohesive in the management of those individuals. So, for example, I would consider a low ranking to be a system that really focuses just on detection, right? Using things such as clinical decision support to identify patients who have acute kidney injury. Again, it's great. It allows for an opportunity for better management and potentially improves outcomes depending on which study has shown to improve outcomes. Then you can go up to the next level, which is really focused on prevention, focused on identifying patients who are at high risk, right? Maybe your clinical decision support turns to identifying those patients who have a certain number of risk factors so that you can step in. There's been some work in pediatric non-ICU patients with the NINJA program where they identify patients who are at high risk, and it didn't dictate their management, but clinicians managed them better once they knew they were at high risk. And so they had improvement in outcomes for those patients as well. And then the high level of ranking would be that where you actually, continue with that follow-up post-AKI to prevent the CKD. So a low is around being more reactive in detection. Medium ranking would be more around prevention. And then the high ranking would be more around the follow-up. And again, you can kind of dabble in each one of these rankings, but if the institution says, we're going to do all these things for detection, we're going to do all these things for prevention, we're going to do all these things for follow-up. And once they've accomplished all of those things, then, they can consider themselves moving up that next rank. And so being, again, very strategic and purposeful about the initiatives that they put in place so that just more of a homogeneous management than individual management by each clinician.
It chimes with what I see in a lot of areas, the notion of sort of passive, reactive, proactive, and then a really true strategic engagement.
From here on, the conversation moved into questions from the online audience. Have a listen.
I've got a few questions I'd like to ask the panel. Specifically, this is for Marlies and John. There's been a lot of change in the way that we think about volume assessment and management in intensive care units. So can I ask each of you, how do you, in your practice, assess a patient's current volume status, and what tools do you use to do that, as well as your hands, eyes and ears?
Such a good question, and it's a question I get asked every single day at the bedside. And assessing, and more importantly, defining and diagnosing euvolemia is so difficult at the bedside. So I think we've all agreed and acknowledged that euvolemia is the optimal fluid status. To diagnose and maintain euvolemia is difficult. What I do is essentially rely on clinical signs. So in the absence of a continuous dynamic tool, I use my clinical skills. I assess patients, I repeatedly assess them clinically. I do straight leg raising. I look for fluid responsiveness, and I accept that not everybody who is fluid responsive on passive leg straight needs fluid. And then I interpret the clinical signs in the context of the situation. So if I have somebody who is hypotensive and becoming more tachycardic, and I have clinical signs consistent with intravascular volume depletion, then I will give more fluid. But if I have somebody who is normotensive, not tachycardic, and the clinical status has not changed, and they have clear signs of organ function, so they're passing urine, they're mentating, and so then I will ignore the fact that a straight leg raising may indicate some responsiveness. So in the absence of proper tools and usable tools at the bedside, it's clinical signs, and I interpret them in light of the clinical situation.
John, what's the situation north of the river? Any different?
Well, there's water in the river, but I think that the key thing when I approach a patient is that to realise that the fluid assessment is really a dual assessment. You're looking for signs of fluid overload, which is interstitial edema, which is going to be potentially a long-term harm to your patient, may put them at very acute harm if they've got something like an abdominal compartment syndrome. But then there is intravascular volume status, which may be correlated or completely divorced from the total amount of fluid overload in the patient. And that's going to be the thing that's critically determining your cardiac output on a beat-to-beat basis. And then you've got to think about the context of the patient. So before one thinks about, to some extent, whether they need fluid or not, you've got to think about whether they're showing signs of inadequate organ perfusion and inadequate cardiac output. And the context of the stresses the patient's undergoing. So surgery is a great example here. You might have somebody who is total body fluid overloaded, intravascularly relatively euvolemic, and a good example would be perhaps a hemodialysis patient who's had some dialysis earlier that morning, who presents with an acute abdomen, needs a laparotomy. They're probably still total body fluid overloaded. Their intravascular volume status is going to be probably just about there, but they're developing abdominal sepsis. They're about to have an anaesthetic and a strong additional venodilation status, and they will need fluid intraoperatively. At some point, that fluid is going to end up in their tissues, and eventually they're going to need renal replacement therapy targeted to try and resolve their intravascular fluid overload. So first of all, you think, to what extent, if hypovolemia is present, is it being manifest in terms of inadequate organ perfusion? To think about the priority, and then to assess separately the circulatory status and all the things that Marlies has said. And you can look at pulse volume variation, you can look at capillary refill, you can look at a number of soft signs that you might integrate together, including the maneuvers like straight leg raising if the patient's appropriate. You could also have a think in a more long-term fashion, usually about their interstitial edema. And you've then got to kind of balance where you are at in the patient's journey and decide which we are going to try and treat more. And so I don't think you can criticize, the anaesthetist presents the patient to the ICU having had a couple of litres of fluid, not necessarily 9 litres or something like that, because they are still tissue overloaded, because that's what you're needing to defend the cardiac output during that acute stressor. But then in the ICU, John, you're going to have to take a longer-term approach.
One thing that is gaining traction is the use of bedside ultrasound to assess hepatic and portal vein flow, with this idea that increased pulsatility represents overfilling of the right side. And in the context of the kidney, as we know, that's important. And let me bring you all back to this concept of the kidney health assessment, and particularly in the context of how can you do that all around the world, depending on your resource status.
I think the kidney health assessment doesn't have to be too complicated. It is really attention to the potential state of kidney function and using simple tests like creatinine and urinalysis, so proteinuria. This can be done preoperatively and postoperatively. And I think it will highlight changes. It will highlight the person who is at highest risk. And after that, I would really seek help from a nephrologist. And more importantly, in the UK for sure, GPs have become very interested in this and have recently, i.e. early this year, published fantastic guidelines together with the Royal College of General Practitioners, how to protect patients with kidney disease or at risk of kidney disease. So I think a dipstick, a creatinine, and a blood pressure is all you need to do. And from then on, it's fairly easy.
Sandy, what are the implications of kidney health assessment management through time in the context of the transition, perhaps, from acute disease back to normal or to a more persistent, reduced function state?
Yeah, I think it even begins with the fact that we need to have better histories, right? We oftentimes don't know, our biggest discussion is, what's the patient's baseline serum creatinine? And we don't have that information. I think it's a little bit better in your integrated health systems in the UK, where you might have better access, but that's not always available to us here in the US. And so, knowing that information, having an appreciation for if the patient has had previous episode of AKI, which we know is a risk factor for subsequent episodes. And so understanding that information would be very useful in the idea for prevention or better management. Again, diligent monitoring clearly throughout the hospitalization, but not just monitoring, right? We have all kinds of serum creatinines that are checked in the ICU, right? They're typically available daily. That doesn't mean we've really looked at them, right? Looked at them for trends, looked at them for differences, looks at how things are changing. And so that's when these monitors for immediate changes are very useful. And then with regards to follow-up, how about we tell the patient that they had an episode of acute kidney injury and that they actually require some follow-up to ensure their kidney health, right? We don't have those conversations with every patient. They don't know they had an episode of AKI. They don't know the importance of follow-up. So those are some ways at which we can emphasize monitoring for kidney health.
Marlies, I'm going to ask you about biomarkers. I've been hearing for 20 years that serum creatinine's dead and that new fancy tests of this function or that particular tubular protein leak are going to help me know exactly when the kidney is failing. And the concept of a troponin for the kidney. Help us and the audience understand that space a little bit. And why are we still using serum creatinine if the promise of biomarkers is so tantalizing?
Well, for a start, creatinine and urine output are biomarkers. So we're already using biomarkers. The question is whether we can complement them with other biomarkers that may be more specific or may be earlier or may give us more information about the cause of acute kidney injury. And the great news is that we have found many new substances which can supplement and complement creatinine and urine output. They're all normal biological products which get released by the body in response to an insult. They have different kinetic profiles. And I strongly believe that the use of and our understanding of these new biomarkers, together with creatinine and urine output, will just give us more granularity. Wouldn't it be nice if we truly knew the cause of acute kidney injury? In nephrology, we still talk about acute kidney injury and then leave it like that and apply a generic strategy. Whereas in all other fields, you wouldn't, if you say somebody has respiratory failure, you don't stop. You say respiratory failure from a PE, and that's why you're going to get thrombolysis. In acute kidney injury, we do not have this. So having additional information which these new biomarkers can provide will give us these opportunities. They may tell us where the anatomical site of injury is. They tell us what the anoxic insult was. Was it the anesthetic, the drug? Was it hypotension? Or was it something completely different? Was it the free iron during cardiac surgery as opposed to hypotension? So if you had some information about what led to acute kidney injury, and you had some information about the potential state, whether it's getting worse or actually getting better, I strongly believe that this will change how we manage acute kidney injury, as it did in all other fields, in oncology, in cardiology, and other fields.
Rather than the recognition of the condition, you think assisting with the differential diagnosis of the cause is where we're likely to see the most benefit.
One thing, it will also help us in research, because we have no therapies, but because that's the reason is we're trialing drugs and then lumping hundreds of causes of AKI together and try out one drug. When in fact the drug may be very good for a particular type.
Yeah, I was also proposing from a health system perspective, I encouraged the idea of prevention, right? And identifying patients early. As Marlies is clearly pointing out, that, the serum creatinine lag. And so if we can see that stress or that damage to the kidney early, again, that's what's going to allow us that better management. And Marlies brings up another great point is we're not saying use these novel or newer biomarkers in isolation. It has to be a whole picture, right? This is one more piece of the puzzle to make us better understand what's going on with the patient. And so I think, and I'm excited about seeing how it plays out for seeing patients who are at risk for drug-associated acute kidney injury. The moment the drug is given, how high does the biomarker get? And maybe that indicates that we should back off on that drug or we should pick something different. Or you know what? The great part about some of these biomarkers is the negative predictive value. We know that they're not at risk. That's okay, status quo, keep going with that therapy. And so all useful information.
So there's a question saying, what are you specifically looking for in a urine dipstick?
Really what you're looking for is obviously proteinuria. Proteinuria is part of the chronic kidney disease staging. Chronic kidney disease has actually sort of gone from a one-dimensional staging where you had a severity of renal dysfunction based on GFR, which could then be kind of tweaked at the upper ends with proteinuria. So people with normal function had a CKD stage 2 when they had proteinuria. It's really adopted a grid classification where you have your GFR-based classification and your severity of proteinuria, recognizing the fact that proteinuria is indicative usually of either some kind of tubular injury or some glomerular injury, potentially in association with hyperfiltration. And so, for instance, in early diabetic nephropathy, you could have a well-preserved GFR, but the presence of proteinuria will strongly predict your risk of progression towards a significant CKD and eventually end-stage renal failure, and also be strongly associated with the risk of developing acute kidney injury. And the two things really act independently, and there's good evidence to show this from a number of large population studies that the risks of adverse events, cardiovascular events, the risk of death and the risk of progressive chronic kidney disease, the risk of acute kidney injury is sort of independently linked to proteinuria and a fall in GFR. And so really assessment just of GFR is a very one-dimensional one. Now, that's not to say it is not difficult. It can be difficult to do a urine dipstick in every patient who is potentially going to come for surgery. Getting urine out of patients is actually not more difficult than getting blood out, but certainly in patients who are having high-risk surgery, patients who are potentially at high risk of covert chronic kidney disease, such as those with diabetes, a formal assessment of albuminuria preoperatively forms an essential part of the risk stratification of these patients.
So for a relative beginner in perioperative nephrology, it's an alarm bell. It's got prognostic significance for a variety of outcomes that none of us would really want to experience. And then there's a bit more nuance in terms of diagnosis if you look at the detail of protein, blood, etc. That starts to allow you to categorise pathology. Yeah,
the severity of proteinuria is obviously important, but even microalbuminuria is a significant abnormal finding that will be. So everybody has a kind of, and these days dipsticks are usually quantified in an automated setting anyway, but any form of detection of protein on dipstick should lead you to doing a formal albumin-creatinine ratio, and that will give you a specific insight, and particularly if the patient is diabetic or hypertensive, you would regard them as at significantly increased renal risk, even if their creatinine appeared to be within normal limits or their GFR was above 60. And that may lead you to tailoring your perioperative medication strategy more in favour of the prevention of acute kidney injury. Blood on a urine dipstick is more difficult to interpret. There's a number of reasons why it could be present, or sometimes you're sort of vicariously detecting something like a uroepithelial carcinoma or something like that, which requires investigation but doesn't have a direct impact on kidney function. But you may detect something like somebody with undiagnosed IgA nephropathy or something like that. And so it would be certainly necessitate investigation, but perhaps a little bit less clearly connected with the perioperative risk.
So thank you very much, guys, for a fabulous discussion.
Thank you also, Andy. So thank you, Marlies, Sandy and John. Really enjoyed the session.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.